Ventricular peritoneal shunt. VP shunt is a long plastic tube that allows fluid to drain from the brain to another part of the body. This drainage prevents the increase in pressure on the brain caused by hydrocephalus. Extraventricular drain. External ventricular drainage is a treatment that allows the temporary drainage of cerebrospinal fluid from the ventricles of the brain, relieving raised intracranial pressure. Neoplastic diseases. Learning objectives. Definition of cancer, etiology, pathophysiology, and sign and symptoms description. To discuss diagnostic tests, to enlighten medical management of cancer, to discuss nursing diagnosis and interventions for patients with cancer. Cancer terminology. Breast carcinoma of the ductal, medullary, papillary cells, lung, small cell, bronchiolo-alveolar, squamous large cell carcinoma, bone, osteosarcoma, Ewing's sarcoma, eye, retinoblastoma. Okay, retinoblastoma. Cancer terminology. Benign tumors are generally slow growing and enclosed in a fibrous capsule, are relatively innocuous, although their location can make them serious, such as tumor located in the brain, are not considered cancerous, that is, they are not malignant, are given names that usually end in a oma, although a melanoma is a malignant skin cancer. Malignant tumors proliferate rapidly, invading neighboring tissues, can metastasize or spread to other sites of the body, are named using the conventions of tissue, cell type, and origin. A tumor of the bone is an osteoma, if benign, and an osteosarcoma, if malignant. Leukemia. Leukemia is a condition in which there is clonal proliferation of malignant stem cells in the bone marrow. Leukemia is present when greater than 25% of blast cells are present in bone marrow. Sporadic acute leukemia. A malignant clonal proliferation (WC) precursor blast cells occupy and inhibit the function of the bone marrow. They may circulate in blood and form leukemic deposits in any tissue. Two types of: one are acute lymphoblastic leukemia, 2 AML, acute myeloid leukemia. All count 75% of paired leukemia. Cells C malignant or resemble like blast cells. Etiology mostly unknown, however may be caused ionizing radiation, cytotoxic drug, HTLV1, HTLV2, genetic factors, types of genes which may mutate to cause cancer, tumor suppressor genes, oncogenes, DNA repair genes, telomerase P53. The environment. Some environmental agents associated with cancer are viruses, tobacco smoke, food, radiation, chemicals, pollution. Pathophysiology. Abnormal stem or myeloid cells proliferation induced by any one of the above mentioned causes. T-cell marker CD2, CD3, CD5, CD7. Monoclonal antibodies test. Tumor or lump. alopecia, fatigue, weakness, nausea, vomiting, muscle pain, lymphadenopathy. Types: retinoblastoma, lung cancer, colon cancer, breast cancer, ovarian cancer, mouth cancer. We will confine ourselves to study breast and ovarian cancer and details, as it has great effect on the baby. Transformation is a multi-step process. Breast cancer. Breast cancer is a major health problem. Current statistics indicate that a woman's lifetime risk for developing breast cancer is 1 in 8. Carcinoma in situ, non-invasive. The disease is characterized by the proliferation of malignant cells within the ducts and lobules without invasion into the surrounding tissue. Therefore, it is a non-invasive form of cancer and is considered stage 0 breast cancer. There are two types of in situ carcinoma: ductal, lobular. Etiology: hormones, estrogen exposure, and the development of breast cancer. BRCA, one gene has been linked to the development. BRCA2 gene identifies risk for breast cancer. Clinical manifestations: breast cancer occur anywhere in the breast, but most are found in the upper outlet quadrant where most breast tissue is located. Generally, the lesions are non-tender rather than painful, fixed rather than mobile, and hard with irregular borders rather than encapsulated and smooth. Nipple retraction and lesions fixed to the chest wall may also be evident. Involvement of the skin is manifested by ulcerating and fungating lesions. These classic signs and symptoms characterize breast cancer in the late stages. Stage 1 tumors are less than 2 cm in diameter and confined to breast. Stage 2 tumors are less than 5 cm or tumors are smaller with mobile axillary lymph node involvement. Stage 3 tumors are greater than 5 cm or tumors are accompanied by enlarged axillary lymph nodes fixed to one another or to adjacent tissue. Stage 3 more advanced lesions with satellite nodules, fixation to the skin or chest wall, ulceration, edema, or with supraclavicular or intraclavicular nodal involvement. Stage 4 all tumors with distant metastasis. Cancer of the ovary. Ovarian cancer causes more deaths than any other cancer of the female reproductive system. Most cases affect women aged 50 to 59. Medical management of cancer: chemotherapy, radiotherapy, surgery, lumpectomy, mastectomy. In case of BC, stem cell transplant, leukemia. Management: bone marrow transplant. Nursing diagnosis: deficient knowledge about cancer and treatment options. Anxiety related to cancer diagnosis. Fear related to specific treatments, body image changes, or possible death. Risk for ineffective coping, individual or family related to the diagnosis of breast cancer and related treatment options. Decisional conflict related to treatment options. Nursing interventions: encourage and support the child family emotionally, teach treatment options honestly, and relieve their anxiety. Prepare the patient for surgery, radiation therapy accordingly. Assess vital signs, blood cells, and respiration strictly. manage post-chemotherapy vomiting, prevent infections by observing aseptic techniques. Preferences, concepts of genetics. This was all about this. Nursing care of children with hematologic alterations, anemia. Anemias, a condition in which the number of RBCs and or the hemoglobin concentration is reduced below normal. 0 to 14 days, HB less than 145 gram per liter. 15 to 28 days, HB less than 120 gram per liter. 1 month to 1 year, HB less than 110 gram per liter. Anemias. The basic cause of anemia is either number 1, an increased loss or destruction of red blood cells. Number 2, an impaired or decreased rate of production. An etiologic classification is based on the various conditions that can lead to either of these results. Classification of anemias: decreased production of RBCs, iron deficiency anemia, aplastic anemia, increased destruction of RBCs, hemolytic anemia, sickle cell anemia, thalassemia, blood loss, iron deficiency anemia, hemorrhagic anemia, severity, mild, HB 110 to 90 gram per liter, moderate HB 89 to 70 gram per liter, severe HB less than 70 gram per liter. Classification of anemias. Morphologic: describe the size of RBCs. Number 1, normocytic. Number 2, microcytic. Number 3, macrocytic. According to the amount of hemoglobin in the cell, describe the color and HB content of the cells. Number 1, normochromic. Number 2, microchromic. Anemia assessment: take health history, careful diet history to identify any deficiency. Evidence of pica, eating clay, ice paste. Observe for manifestations of anemia: muscle weakness, easy fatigability, frequent resting, shortness of breath, poor sucking infants. Manifestations of anemia: pale skin, mucous membranes, lips, nail beds, and conjunctiva. Waxy pallor seen and severe anemia: capillary refill, no change color, rapid pounding heartbeat. CNS manifestation: headache, dizziness, lightheadedness, irritability, slowed thought process, decreases attention span, apathy, depression. Causes of anemia: nutritional deficiency, iron, folate, B12, increased destruction of RBC, sickle cell anemia, impaired or decreased rate of production, aplastic anemia, excessive blood loss, hemophilia. Iron deficiency anemia causes: inadequate supply of iron, impaired absorption, blood loss, excessive demands for iron required for growth, inability to form hemoglobin. Iron deficiency anemia signs and symptoms: due to tissue hypoxia, less than lack of energy, easy fatigability, pallor. Diagnosis: CBC with different red cells indices, MCV, MCH, MCHC. Iron studies, physical exam. Medical treatment: supplement with ferrous sulfate dosage vary with age, dietary counseling. Iron deficiency anemia. Nursing assessment and interventions: educate parents about nutrition, explain laboratory testing, teach parents proper administration of iron preparation, caution about high toxicity of iron. Severe anemia: impaired healing and loss of skin elasticity, thinning and early graying of the hair, abdominal pain, nausea, vomiting, anorexia, low-grade fever. Aplastic anemia is a condition wherein injury to or abnormal expression of the stem cells in the bone marrow results in the production of inadequate numbers of erythrocytes, leukocytes, and platelets. Can be hereditary or acquired. The hereditary form of aplastic anemia, Fanconi's anemia (FA) is a rare autosomal recessive disorder that develops early in life and is accompanied by multiple congenital abnormalities. Aplastic anemia. The age of onset varies. Typically, the first sign noted is increased bruising caused by the decreased number of platelets, vulnerability to infection because of the decreased number of WBCs. When the RBCs have decreased in number and the signs and symptoms of anemia began to manifest. Pallor, weakness and difficulty breathing, impaired growth and development. Criteria for severe aplastic anemia. Severe aplastic anemia, neutrophils less than 2 multiplied by 10 power 9 cells per liter. Platelets less than 50 multiplied 10 power 9 cells per liter. Reticulocytes less than 0.5%. Bone marrow cellularity less than 20%. Nursing care: minimize physical exertion and emotional stress. Anticipate and assist in those activities of daily living that may be beyond child's tolerance. Provide play activities that promote rest and quiet but prevent boredom and withdrawal. Encourage parents to remain with child. Increase oxygen to tissues. Position for optimum air exchange. Administer supplemental oxygen if needed. Help replace blood elements. Administer blood, fat cells, platelets as prescribed. Promote adequate intake of iron-rich foods. Encourage exclusive breastfeeding of infants for 4 to 6 months after birth. Diet rich with food sources of iron, meat, liver, fish, egg yolks, green leafy vegetables, nuts, whole grains, iron, fortified infant cereal and dry cereal. Feed milk as supplemental food. An infant's diet after solids are begun. Administer iron preparations as prescribed. Give between meals. Administer with fruit, juice, or multivitamin preparation. Don't give with milk or antacids. Give fluid preparation with dropper, syringe, or straw to avoid contact with teeth. If the child is getting enough iron, stools should be a terry green color. Iron supplements. Although oral iron supplementation is generally perceived as a safe treatment alternative, an overdose can be lethal for children. Initial signs and symptoms of overdose: vomiting, abdominal pain, bloody diarrhea. These manifestations are typically followed by shock, lethargy, and dyspnea. Often the child will appear to improve before the onset of severe metabolic acidosis, coma, and death. Urgent treatment is essential and includes flushing out unabsorbed pills, administration of Desferal, and supportive therapy. Blood transfusion. Nursing responsibilities. Positively identify donor and recipient blood types and groups before transfusion is begun. Verify with one other nurse or physician. Transfuse blood slowly for first 15 to 20 minutes. Remain with patient and an event of signs or symptoms, stop transfusion immediately. Maintain pattern IV line. Notify physician. Insert urinary catheter to monitor hourly outputs. Monitor for evidence of shock. Save donor blood to re-cross match with patient's blood. Blood transfusion complications: hemolytic reactions, febrile reactions, allergic reactions, circulatory overload to rapid transfusion or excessive quantity of blood transfused. Air emboli may occur when blood is transfused under pressure of hypothermia. Allow blood to warm at room temperature 1 hour. Hyperkalemia and massive transfusion are patient with renal problems. Sickle cell anemia, a hereditary disorder in which normal adult hemoglobin (HbA) is partially or completely replaced by an abnormal hemoglobin, causing distortion and rigidity of red blood cells under the condition of reduced oxygen tension. Sickle cell anemia is part of a group of diseases called hemoglobinopathies. Sickle cell anemia. Sickle cell anemia is an autosomal recessive disorder. The inheritance is described as intermediate because the gene is partially expressed in the heterozygous state and completely expressed in the homozygous state. Sickle cell anemia is found primarily in the black race, although infrequently it affects whites. Sickle cell anemia manifestation: take health history, especially regarding any evidence of sickling crisis and history of the disease in family members. General: growth retardation, chronic anemia, delayed sexual maturation, marked susceptibility to sepsis. Other signs and symptoms: weakness, anorexia, joint, back and abdominal pain, fever and vomiting. Chronic leg ulcers are common in adolescents and adults and are thought to be the result of thrombosis and decreased peripheral circulation. Sickle cell anemia, vaso-occlusive sickling crisis, pain in areas of involvement, signs of ischemia, extremities, painful swelling, hand-foot syndrome, painful joints, abdomen, severe pain resembling acute surgical condition, cerebrum, stroke, visual disturbances, chest, pseudo pneumonia, protracted episodes of pulmonary disease, liver, obstructive jaundice, hepatic coma, kidney hematuria, sequestration crisis, pooling of large amounts of blood, hepatomegaly, splenomegaly, circulatory collapse. Diagnostic evaluation: for screening purposes, the sickle dex is commonly used. If the test is positive, the hemoglobin electrophoresis is necessary to distinguish between those children with the trait and those with disease. Sickling test: sickle cell slide preparation. Place a drop of blood on a slide and cover it with a sealed cover slip to produce deoxygenation. Eventually, sickling of the red blood cell occurs. Hemoglobin electrophoresis, fingerprinting. This test is accurate, rapid, and specific. Nursing management: increase tissue oxygenation and prevent sickling. Family teach: avoid strenuous physical exertion, emotional stress, decrease oxygen environment, promote hydration, prevent infection, increase tissue oxygenation, administer oxygen, promote circulation through passive range of motion, exercise, relieve pain. Sickle cell anemia causes genetic transmission. Two parents with the trait have 25% chance of having child with SCD, found primarily in blacks. H- HB is partially completely replaced by HBS with dehydration, acidosis, hypoxia, and temperature elevations. HBS sickle cell anemia, pathophysiology, vaso-occlusion from sickled RBCs, increased RBCs destruction, splenic congestion and enlargement, hepatomegaly, liver failure, renal ischemia, hematuria, cardiomegaly, heart failure, stroke. Sickle cell anemia signs and symptoms: exercise intolerance, anorexia, gallstones, chronic leg ulcers, growth retardation. Sickle cell anemia medical management: supportive, symptomatic crisis, bed rest, hydration, electrolyte replacement, analgesics for pain, blood replacement, antibiotics, oxygen therapy. Sickle cell anemia nursing care: minimize tissue deoxygenation, promote hydration, minimize crisis, pain management, administering blood transfusions, encourage screening and genetic counseling. Parent education. Hemophilia. Hemophilia is said to be factor 8 or factor 9 deficiency. Prolonged bleeding anywhere in the body causes X-linked recessive disorder, defects in platelets, and clotting factors. Diagnosis: history of bleeding episodes, evidence of X-linked inheritance, medical management. Factor 8 concentrate, DTAVP, vasopressin. Hemophilia nursing care: prevent bleeding, recognize and control bleeding, rise, rest, ice, compression, elevation, prevent crippling effects of bleeding, client education, avoid competitive sport. Idiopathic thrombocytopenic purpura causes acquired hemorrhagic disorder of unknown origin, probably an autoimmune response to disease-related antigens. Diagnosis: platelet count less than 20,000, abnormal bleeding time and clot retraction. Signs and symptoms: petechiae, bruising, bleeding from mucous membranes, prolonged bleeding from abrasions. Medical management: supportive, steroids, anti-D antibody, splenectomy. Idiopathic thrombocytic purpura. Nursing considerations: client parent teaching, no contact sports, no aspirin, prevent infection, blood transfusion, complications, hemolytic reactions, chills, shaking, fever, dyspnea, flank pain, progressive signs of shock, febrile reactions, allergic reactions, urticaria, flushing, wheezing, circulatory overload, blood transfusions. Nursing care: take versus before administering blood, check ID of recipient with donor's blood type, administer 50 ml or 1 by 5 volume slowly, stay with the child, administer with the NS on PEGI bag setup, use appropriate filter, use within 30 minutes, infuse within 4 hours. If reaction suspected, stop transfusion, maintain patent IV line with NS, take VS, notify practitioner. B. Thalassemia, group of inherited autosomal recessive blood disorder of Hb% synthesis characterized by anemia, which is mild and severe. Types: thalassemia minor, mild anemia; thalassemia intermediate, severe anemia; thalassemia major requiring transfusion. Sign and symptoms: severe anemia, headache, weakness, hypochromic folic acid deficiency, bone deformities, microcytic anemia, frequent epistaxis, jaundice, pallor, bone pain, darkening of the skin, complication, heart failure, splenomegaly, failure of Thrive, liver cirrhosis, CCF, cholelithiasis, death of the patient, lab investigation. HB electrophoresis treatment: iron chelating agent with vitamin C, folic acid, maintaining HB level, bone marrow transplantation, blood transfusion. Hodgkin diseases and non-Hodgkin lymphoma. Thomas Hodgkin. The lymph system and lymphoid tissue. The lymph system, also known as the lymphatic system, is part of the body's immune system, which helps fight infections and some other diseases. It also helps fluids move around within the body. The lymph system is composed of mainly of lymphoid tissue, includes the lymph nodes and related organs that are part of the body's immune and blood forming systems. Lymph: a clear fluid that travels through the lymph system, carrying waste products and excess fluid from tissue, as well as lymphocytes and other immune stem cells. Lymph vessels: small tubes similar to blood vessels through which lymph travels to different parts of the lymphatic system. Lymphocytes: lymphoid tissue is made up of cells called lymphocytes, a type of white blood cell that fights infection. There are two major types of lymphocytes: B lymphocytes, B cells, and T lymphocytes, T cells. Normal T cells and B cells have different jobs. B lymphocytes: B cells help protect the body from germs, bacteria, and viruses. They do this by maturing into plasma cells, which make antibodies, immune proteins. These antibodies attach to the germs, marking them for destruction. Almost all cases of Hodgkin disease start in B lymphocytes. T lymphocyte: there are several types of T cells, and each has a special job. Some T cells can directly destroy certain kinds of bacteria or cells infected with viruses or fungi. Other types of T cells play a role in either boosting or slowing the activity of other immune system cells. Lymph nodes. Lymph nodes are small bean-shaped, bean-sized collections of lymphocytes and other immune system cells found throughout the body, including inside the chest, abdomen, and pelvis. They can sometimes be felt under the skin and the neck, under the arms, and in the groin. Lymph nodes are connected to each other by a system of lymph vessels. Lymph nodes get bigger when they fight an infection. Lymph nodes that grow in reaction to infection are called reactive nodes or hyperplastic nodes. These often hurt when they are touched. People with sore throats or colds might have enlarged uh, neck lymph nodes, and an enlarged lymph node is not always a sign of a serious problem, but it can be a sign of Hodgkin disease. Bone marrow. The bone marrow is the spongy tissue inside certain bones, which is where new white blood cells, including some lymphocytes, red blood cells, and platelets, are made. Thymus. The thymus is a small organ behind the The thymus is a small organ behind the upper part of the breastbone and in front of the heart. It is important in the development of T lymphocytes. Digestive tract. Okay, the back of the throat, adenoids and tonsils, stomach, intestines, and many other organs also have lymphoid tissue. Spleen. The spleen is an organ under the lower part of the rib cage on the left side of the body. The spleen makes lymphocytes and other immune system cells and filters out damaged blood cells, bacteria, and cell waste. Hodgkin lymphoma is a cancer of the lymphoid system. The lymphoid system is made up of various tissues and organs, including the lymph nodes, tonsils, bone marrow, spleen, and thymus. These organs produce, store, and carry white blood cells to fight infection and disease. Lymphoma epidemiology. Third most common cancer in children in the US, contrast second most common cancer in Turkey. Number 1, leukemias. Number 2, brain tumors. Annual incidence of 13.2 per million children. Major types include Hodgkin's and non-Hodgkin lymphomas. 60% are non-Hodgkin lymphomas, 40% Hodgkin's lymphomas. Types of Hodgkin disease. The two main types are classic Hodgkin disease, which has several subtypes, nodular lymphocyte, predominant Hodgkin disease. All types of Hodgkin diseases are malignant, cancerous, because as they grow, they may invade and destroy normal tissue and spread to other tissues. There is no benign non-cancerous form of Hodgkin disease. Classic Hodgkin disease, nodular sclerotic Hodgkin disease, mixed cellularity Hodgkin disease, lymphocytic rich Hodgkin disease, lymphocytic depleted Hodgkin disease. Reed Sternberg cells, also known as lacunar histiocytes for certain types, are different Gantt cells found with light microscopy and the biopsy from individuals with Hodgkin's lymphoma, aka Hodgkin disease, a type of lymphoma. What causes it? Studies have suggested several infectious agents. EBV, human herpes virus, CMV, high EBV titers, and the presence of EBV genomes and Reed Sternberg cells. Surface markers suggest T cells and B cells lineage. Reed Sternberg cell. How do they present? Clinical presentation. Most common presentation in children is asymptomatic cervical lymphadenopathy, painless, firm, not inflammatory. Extension from one lymph node group to another. Two-thirds of patients have mediastinal adenopathy at presentation, cough or SOB, shortness of breath, a significant compression, and frequently presents as axillary or inguinal adenopathy. Extranodal metastasis. Hodgkin's spreads through the lymphatic system. Most frequent sites of extranodal involvement and decrease in order of the frequency. Bone marrow, bone, liver, lung, pericardium or pleura. Paraneoplastic syndromes, more likely seen in relapsing patients with widespread disease and non-Hodgkin lymphoma, hematologic, skin, nervous system, kidneys. Diagnostic workup. Tissue is needed for definitive histologic diagnosis. Sample the node that is most accessible. PE with careful and measurement of lymph nodes labs. CBC, ESR, LFT, renal function test, alkaline phosphatase elevated, immune response decreased. Diagnostic and staging workup. Cervical area, ultrasound, CT, MRI. Thoracic imaging, chest X-ray, CT scan of the chest, anti and middle mediastinum, best visualization of lung, parenchyma, pleura. Abdominal imaging, ultrasound, CT, MRI. Lymphangiogram, most reliable method of detecting retroperitoneal lymph nodes, rarely done in children. Diagnostic and staging workup. Gallium scan, PET scan, search the body for other involvement. Staging, laparotomy, not used routinely anymore, previously done routinely as part of staging. Bone marrow biopsy, recommended for stage 2B or higher. Bone marrow involvement and presentation is rare. Bone scan, recommended for kids with bone pain, elevated alkaline phosphatase or extranodal disease. Sign and symptoms. Swollen lymph nodes. The affected lymph nodes are usually found in the neck or the above collarbone and less commonly under the arms or in the groin. The lymph nodes are usually painless, firm, rubbery, and movable in the surrounding tissue. Poor appetite, weight loss, night sweats, fever, fatigue may also be experienced by children with Hodgkin disease. They are systemic symptoms with a more generalized effect on the entire body. Itching, pruritus is another symptom in patients with Hodgkin disease. Itching can be mild or severe and tends to occur more often in patients with advanced disease. Diagnosing Hodgkin disease. Evaluation begins with a complete medical history and physical examination. Examine child's lymph nodes and abdomen thoroughly. The presence of small soft lymph nodes are less concerning than nodes that have been increasing in size or are significantly enlarged. An enlarged spleen or liver may indicate generalized disease, while a chest X-ray is usually performed prior to any biopsy or lymph node, or rarely other site biopsy is needed to diagnose the disease. Diagnostic findings. Laboratory studies do not establish stage of the disease but are important. A complete blood count, erythrocyte sedimentation rate, kidney and liver function tests. Imaging studies, not all tests are needed for every patient. Chest X-ray, computer tomography scan, MRI, bone scan, bone marrow biopsy. This is all about the disease and determining the extent of Hodgkin disease we will study later on.